Well, we're here with Dr. Rinaldi. Dr. Rinaldi, a podiatrist in the Brooklyn area. Is that right, Dr. Rinaldi?
That's correct. Brooklyn, New York.
Brooklyn, New York. Well, Dr. Rinaldi, tell us a little bit. I mean, most of us, we, to a degree, we think a podiatrist is a podiatrist is a podiatrist. And while that might be true, I'm sure there are also some differences in philosophy. Some podiatrists are a little bit more what's called aggressive. They're more equipped with surgery equipment and they do more sports injuries, other ones less. Tell us a little bit what your philosophy in the practice is, the type of patients you treat, and maybe even why did you become a podiatrist? What made you becoming a podiatrist? Do you mind shedding some light on that whole thing?
No, not at all. Actually, podiatry for me was a position that I found having injured myself. I was a baseball player in college, had a terrible sprained ankle, put me out for about 6 months. I was redshirted and saw a local podiatrist who actively treated me very successfully. I was able to get back to the team, and it kind of created a little spark. When I realized I wasn't going to sign a big contract with the Dodgers, I decided to concentrate on my studies a little bit and applied to podiatry college. Regarding your other question, what really separates podiatrists in general is the education level that the podiatrist undertakes probably following the podiatry degree. All podiatrists go through either a Bachelor of Science or a Bachelor of Arts program. They graduate from podiatry school with 4 years of training. But then it's usually the additional training that separates what a podiatrist does, because it also separates how they specialize. In my particular case, I was lucky enough to do a 3-year surgical residence in podiatry and podiatric medicine. So my practice originally was surgically and medically oriented, and then began to evolve in terms of some of the biomechanics of podiatry, the orthopedic needs of patients who are in need of foot problems. Practices in a podiatry setting really are, so varied in terms of the population. My practice, I practice in a very nice community in Dyker Heights, Brooklyn, New York, very close to the Verrazano Bridge. And we have a blue-collar population, and our average age runs from about 3 years old to whatever. Our mornings are usually packed with our senior citizens. Our afternoons are usually packed with our teachers and school children, and our evenings are our blue-collar workers that will come off the train, off the buses, those that are coming in from Wall Street. And the problems are so varied. We'll treat things such as a simple flat foot, where a patient comes in and suddenly has a problem with their ability to bear weight on their foot. We'll treat certain deformities such as hammer toes and bunions. We'll treat injuries for the athlete that comes in, the weekend athlete. We see a lot of this with a lot of our female patients who decide to go out on a jogging program or run along with their spouses or their boyfriends or their girlfriends. And we'll treat things like ankle sprains and Achilles tendonitis, plantar fasciitis, which is probably one of the biggest problems associated with a podiatry practice in our patient population pool, those who have heel spurs and things of that nature.
Just for 1 second, I'm sure we're going to go a little bit more into that, but just for 1 second, to tell us what is plantar fasciitis actually about. Just give us a layman's definition, if you don't mind.
Yeah, quite simply, as I explain it to my patients, there are 3 bands on the bottom of the foot. If you put those bands on the heel area and extend them almost as if they're rubber bands to the metatarsals, all on the bottom, all underneath the foot, that's called the fascia, Fascia. And most times when a patient gets up in the morning and has pain, or gets up from a period of rest, whether sitting in a chair or driving for a long period of times, and gets out of that chair and starts to have discomfort, that's usually a fascial pain. Naturally, we must be careful because it can mimic other things, but most commonly that's a fasciitis.
Okay, good. Well, if you don't mind, thanks for explaining that. Let's go, continue telling us some of these things you
interesting enough, as you were posing the question, it's important that people recognize that a podiatrist is skilled in many, many disciplines. Obviously, the foot is connected to the rest of the body, so we're involved with the circulation of the foot. A podiatrist, first thing when they screen a patient, will determine how their pulses, they're called their pedal pulses, are in terms of how it is beating in relation to the heart. That's very important when we're treating things such as infection. We have to know about the circulation, because if that circulation is not good, we had best refer that patient to a vascular specialist and start to coordinate a team approach in treating the patient's pain. So when we recognize pain, we have to first look at the circulation of a patient. To some extent, we have to be dermatologists. Patients will come in with a myriad of skin conditions. We'll treat the most sophisticated or evaluate the most sophisticated conditions, such as malignant melanoma, glomus tumors, fungal toenails. We'll treat things such as verruca, multiple warts, mosaic warts. If it exists on the foot from a skin condition, we have to be very well versed, whether it to be treated by the podiatrist or, again, a team approach with a dermatologist. To an extent, we have to be very well trained in the biomechanics of the foot, how a foot functions, why it functions, what's created that bunion, what's created that hammer toe. It's not simple enough anymore to just simply correct a deformity by surgical intervention. As a matter of fact, surgical intervention may not be necessary if we understand the mechanics. That again leads me to the education of the podiatrist. Is that podiatrist board certified in surgery and in a discipline we call podiatric orthopedics? He should be, or she should be, to give you the best opportunity to have many, many approaches to treatment. Today in podiatry, the field isn't narrowing as far as how we treat. It's expanding with the advent of lasers. Lasers originally, I guess, started out with treatment for the eyes, and today podiatrists are armed with this type of treatment. Lasers today can treat pain. We treat capsulitis, fasciitis that we talked about before, tenosynovitis. We treat heel spurs. And there are other programs where the laser can be utilized for skin conditions such as warts, fungal toenails, cosmetically. My goodness, how podiatrists now have... Yes, Mr. Flash, was there something?
No, it's just that, it looks like that podiatry has not been bypassed by modern technology.
That's very true. Very true.
It's great. And for instance, one thing, I don't know whether you so far mentioned it, I know that, for instance, as you said, the foot is connected to the rest of the body. In fact, if we really look at it, the foot carries the rest of the body, right? So, they keep saying that, he carries a lot of weight on his shoulders. Well, that might well be, but his shoulders are still on his feet somehow, so the feet carry even more, right?
No, that's true. I always use the analogy. I tell my patients the foot is kind of like the tires on a car. And if you're wondering why your steering wheel is shaking or your spine is shaking, it's probably because your tires or your feet are a problem.
Correct. What's that thing called? That big illness, which you haven't mentioned, which also you guys are very heavy detecting. Forgot it. The thing with the blood, where you have to amputate a foot if it's not cured.
Well, you're probably referring to the vascular problem associated with gangrene and infection.
No, I'm referring to the other one, to the Oh my God! The thing which so many have, the people with blood sugar high and
diabetes.
Diabetes, that thing,
Okay. Yes. Yeah. Podiatrists. That's the medical hat that we must wear. Mm-hmm. That's where the podiatrist, who again has the training and the residency programs that have addressed these things in my time as a podiatrist. I've been lucky enough to be associated with diabetic foot clinics, limb salvage clinics, and it's a major problem. It's a major problem. However, again, as we talk about podiatrists, I think podiatrists, in their recognition of the problems associated with diabetes and the foot, have come such a long way in the prevention of amputations. And that's why when you first mentioned amputations, it was so far from my mind, because probably, Mr. Flash, I believe I've lost you.
Are you here again? We did have a little break up here.
Okay, my screen is blank, but I will continue to talk then.
It's probably your screensaver.
Oh, maybe so. Okay. Yeah, there you are. Okay. In our practice today, there doesn't come a day when we will treat a patient that would have had a potential terrible problem years ago, but now we're able to control, again, with new technology, with different antibiotics, and that team approach with your vascular and infectious disease specialists buddying up with us in a hospital or office setting.
Well, wonderful. Dr. Rinaldi, that was very, very enlightening. It's nice to know that it's important to know, I think, they're all the foot places. I mean, we all know that, if you shoot yourself in the toe and don't have a toe, I mean, it's a little tiny thing, but it's very, very powerful in the whole body, the way you walk and what everything happens. It's good to know that there is treatments out there, and that modern science has not bypassed that area. And very interesting story on how you became a podiatrist, kind of like, you became a believer, and that's wonderful. We'll talk more about it. Thanks a lot, Dr. Rinaldi.